So I drew, I guess, the short straw, and I get to do delirium, and then a related topic of TBI. So we have to go through both of those for the entire hour. I think most of you probably know me at this point, but my name's Foreman, neurology trainer, intensivist, also did EEG for a year, and so my background's kind of neurophysiology and ICU. So delirium's kind of interesting, actually, and the picture that you see here actually was a series of paintings done by someone as he descended into a schizophrenic state, but it kind of plays into what we're talking about here. But this is the same cat drawing drawn at different stages of madness, essentially, by a guy at the turn of the century. Anyway, so what we're going to do is define delirium, understand the risk factors, and describe the impact of delirium on patients in the ICU and how to manage it. I apologize in advance for talking fast, but I got to do it all in 20 minutes because then we got to get to TBI. I'm going to follow a little bit the outline of the SCCM's pain, agitation, delirium guidelines, which were put out in 2013. The levels of evidence that are used for that particular paper are as follows. The level of evidence or the quality of evidence is represented by A, B, and C. The recommendation strength, weak or strong, is represented by number, and plus or minus indicates the treatment effect, whether it's positive or negative. I'm going to start with the premise that delirium is not a disease. I think most of you guys probably recognize this, but it's good to just say it and just kind of be upfront with it, you know, acknowledge it. It's not. Coma is not a disease. You don't go to a family and say, I'm sorry, your family member has coma. So you don't do the same with delirium. But I'm actually going to take it a step further and introduce the idea that delirium is a disorder of consciousness, actually. So just like you talk about coma, you can also refer to delirium. This is a scheme that came out in 2010 that puts disorders of consciousness in this rubric of arousal there on the y-axis and attention, or excuse me, arousal on the x-axis and awareness on the y-axis. And as you look at this, it seems hopefully intuitive to you that someone who is not aroused and does not have any awareness is comatose. And hopefully all of you in the room so far in the talk have a full level of arousal and full awareness of what I'm saying, and therefore you have conscious wakefulness. And as that changes throughout the talk, you'll get drowsier and drowsier and go into a light sleep. And so you've got these different kind of areas. What I'd like for you to be able to do is at the end of this 15 minutes, after an explanation of what delirium is, you should be able to pin the delirium on the chart, and we'll actually try to fit it into this scheme. See, it doesn't exist there currently. All right, so let's talk about some terms then, because I think this actually is what informs the concept of delirium. As it stands right now, most of us kind of see it in a phenomenological fashion, right? We see a patient who's agitated, we go, oh, they're delirious, right? Or you use it colloquially, like you would for someone, maybe a friend who's kind of acting goofy. You're just being delirious, you didn't get any sleep last night, right? But there's actually some very specific terminology that's important to tease apart. One is the idea of vigilance and wakefulness. Vigilance is the blanket term that means someone is aroused to some degree. Wakefulness is what you use when someone has sleep-wake cycling. So all of us wake up in the morning and are currently in a state of wakefulness. Your patients may not have sleep cycles, right? We've got literature that suggests that most people do not have sleep cycling when they're in the intensive care unit. So you'd say those people exhibit vigilance when they have eyes open and they're looking around the room. You can't necessarily say they have wakefulness. But those are terms that you should be aware just relate to someone's level of activation. And vigilance or wakefulness is the equivalent of turning on a spout and basically allowing all of the stimulation that exists around you to enter your brain. So vigilance and wakefulness are things that just prime your brain basically to receive input. And that input is everything from the feel of your butt on the chair to the flicker of the lights to the taste of whatever you eat, right? So it's everything all coming into your brain at once. Thankfully, I had this thing called attention, though. And attention, as it turns out, neuroscientifically, is a concept of a sieve that takes all of that input and unconsciously or subconsciously processes it. So you're not paying attention to how your butt feels in the chair right now because your brain has not said that that's something that you need to be aware of. What you are aware of is me talking because your brain is sensing or hearing my voice and deciding that that's something it wants to pay attention to. In a couple of minutes, you'll probably want to pay attention to something else, right, because your brain says it's more important. But attention specifically acts as something that inhibits all of these other stimulation that you experience by being awake from injecting itself into your awareness. And that leads me to the last concept, which is consciousness, and that's kind of this waffly philosophic term, but what I'm referring to specifically is conscious awareness. That is, that you are aware of what you are aware of. That's something that you have in your brain that you're aware of. Be aware that conscious awareness of something takes a stimulation that's longer than 50 milliseconds, right? So it's not the flicker of the light bulb. You can't really be aware of that because it happens so quickly. And it actually requires about a 300 millisecond delay for the stimulus to get into your brain, for your attentional networks to decide it's sufficiently interesting enough to catalyze this kind of kindling effect and to generate the sequence that make something in your conscious awareness. So everything that you're experiencing right now, everything you're aware of, actually happened 300 milliseconds ago, just so you know. You're living in the past. All right? So I want to demonstrate this a little bit to you, because I think it's important to understand these concepts in kind of a gestalt sense, because you're going to be able to apply it to your patients, right? All right, so watch this video. See if I can make it bigger. There we go. Let's watch the video. Ready?
Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones to those stairs, sir. But I was polishing my petunias in the poppy chair. Constable, arrest Lady Smythe. How did you know, madam, as any horticulturist will tell you, one does not plant petunias until May is out. It's just a matter of observation. The real question is, how observant were you? Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, son. But I was polishing my petunias in the rocking chair. Constable, arrest Lady Smythe.
So the message is important too. Look out for cyclists. So, so your attention filtered out all of that other stuff happening in the background. Your brain did not tell you that any of that was important because you were paying attention. You had conscious awareness of what the detective was saying and that whole narrative that he was portraying.
This is a test.
We don't need to do any more. All right. So as a corollary to that, the concept of awareness is complicated by the fact you can't be aware of more than one set of things at once. So see if you can count or see or be aware of all 12 of the black dots that are here in this picture. You guys have probably seen this on the internet. It's making its way through the meme sphere, right? So as your eyes jerk across the screen and try to count all 12 black dots, you'll find you can only see at most 3 or 4 at the same time, right? So your awareness has to shift to be consciously aware of any specific group of black dots, but you can't see them all at once. So your brain's only able to take in certain amounts of information and process them and make you aware of them at any given time. You can only be aware of one set of selected inputs at a given time. Your attention is what filters that and brings it to your awareness. All right. So now think about it in the context of your poor delirious patient. They are vigilant or wakeful. They have a faucet worth of stimulus coming at them for which their attention is broken. So now their brain is unable to filter all this information. And faced with a ton of stimulation, faced with 12 different dots in front of them, their conscious awareness flitters back and forth between them trying to make sense of it all. That make sense? And so now they suddenly have to deal with multiple different chunks of awareness at any given time that shifts rapidly, just like your eyes were doing across that grid. So let's take a look at what that looks like in a for real patient. This is a 61-year-old guy who's just in the neuro ICU. Some of you probably put a chest tube in him here in this room, who had a left ICH about a year ago and recovered to some degree, but then developed this whopping left MCA recrudescence syndrome of left MCA stroke that he had a year ago, and was found to have a big left perimnemonic effusion. This is within a couple hours of his admission. Watch as what he's aware of shifts. So he looks up, and then he loses it. He looks up again, loses it. Suddenly he's aware of his restraints. He's aware of his fully. He's aware he needs to get out of bed. And he's just shifting constantly because all of that stimulation is just going in unfiltered, right? Then he goes back to sleep, or whatever he's doing, and then he gets back up. In and out, constantly. So that's what delirium looks like, and now you know why. And so this is the SCCM definition, and I'm going to caveat this with this definition is kind of a squirrely one, but they call delirium a syndrome characterized by cerebral dysfunction, whatever that means, with a change in baseline mental status and attention, and disorganized thinking or altered level of, I don't know what any of that means. The two components of this are consciousness, which really is awareness and attention, and cognition, so your memory, orientation, language, or perception. And these are important in the new definitions as well. So that definition was based on the DSM-4, which is what we all grew up with as a psychiatric textbook in med school. And they do define it as this disturbance of consciousness. But what is consciousness, right? That's a philosophical construct. The idea of conscious awareness is something that's only really recently been in the neuroscience literature. And so the DSM-5 actually sort of corrects that to some degree. And so this is really the definition I want you to be aware of. It's a disturbance in attention specifically. And as a result, awareness. You can't attend to something, you can't be aware of something if you can't attend to anything specifically, or if your attention is unable to filter that information in a rational way. It's an acute change. It can't be someone who's constantly like this. And it has to have a disturbance in cognition, meaning that your inattention and therefore inability to focus on one thing in general makes it to where you can't orient. You can't use language because what you're saying is not going to make sense, right? Or you can't encode a new memory. So it's going to affect your cognition. And this is to distinguish what you guys are going to be doing probably in the next few minutes, which is you lose your attention and start kind of maybe drifting off to sleep or paying attention to the clock or something else. I can snap you out of that. That's not creating a problem with your cognition. That's simply your inattention, right? So that's a very different thing. So it has to be something that affects your cognition. And it can't be, this is also crucial, it can't be in the setting of reduced arousal, i.e. coma. So you can't apply delirium to a comatose patient. All right, so the new definition makes a lot more sense. It's really an impairment in attention. Everything else, conscious awareness, defects in cognition, all arise from that attentional problem. There's a bunch of subtypes, which you guys probably know. There's agitated, which we just saw in the video. There's hypoactive, which I would have shown a video of, but it's fairly boring. They just kind of sit there. And then there's mixed, which it kind of actually was what he was doing. He would have periods where he wasn't doing anything, and then he would have periods where he was agitated. So you could actually call it mixed, depending on how slowly he cycled. And then be aware that delirium with a withdrawal syndrome is sort of a separate subtype. You treat it differently, right? A person with alcohol withdrawal-related delirium is going to be treated with benzos. A patient with medically induced delirium, benzos are probably not something you want to use for reasons that I'll show you. How do you diagnose delirium? So the CAM-IC, or the confusion and agitation method used in ICU patients, which was designed by Wes Eli and Vanderbilt over years and years and years, actually has a pretty reasonable receiver operating curve. But be aware that it was tested in predominantly agitated delirium patients. And so the hypoactive delirium patients have a reduced sensitivity. Still, it's better than the intensive care delirium screening checklist, which is the only other test that's got reasonable validity. There's other ones out there, they just haven't been as well validated. So this is what's in the SCCM guidelines. But you can do this at bedside. You don't necessarily need to use the CAM, which is what our nurses do every 12 hours. Test your patient's attention. That's all you need to do. And as it turns out, if you do the months of the year backwards, which is what MOTYB stands for, that actually has an 83% sensitivity for a positive CAM if you fail at that task. That's pretty darn good, right? So the months of the year backwards, you simply ask him to repeat the months of the year, going from December backwards to January. Brian, can I pick on you for a second? Sure. I want you to give me the months of the year backwards. Start with December. Ready? Go.
December, November, August, July, June, May, April, March, February.
All right, so he gets December to January in 10 seconds. Beautiful way to quantify attention in your patients, and you'll find it changes. In the neuro ICU, where people can't do that all the time, 20-to-1 backwards works fine. Neither take a great deal of intelligence or education, unlike the MMSE, which is what we're used to thinking of in terms of attention tests. You don't have to know how to spell, you don't have to do serial calculations. It's just as simple as monthly or backwards. But in case you really got generous and want to do a full CAM, this is what it consists of. Is the change acute? Is there inattention? And they actually do this test for patients who are nonverbal. You just squeeze when you get to a letter that's a double A, or a single A rather. And then they ask about altered levels of consciousness because you, again, want to rule out the patients who are comatose. And if you have a normal level of arousal, so you're like us in the room, then you try to figure out if it affects your cognition. So this is what kind of rules out the sleepy patient who's just tired because maybe they got a little opiate and they're a little drowsy. And it's a binary test. It's positive or negative. So this same guy gets a chest tube, gets antibiotics. This is less than 24 hours after the video you just saw.
Good morning. How are you, sir? Fine. This person are you visiting with you? Yeah? What's his relationship with you? Yeah, good. Your speech is much clearer today. How do you feel like the speaking is compared to his baseline? A little more humble, less articulate.
So he's not back to baseline, right? But he's answering
How
questions.
do you move this arm normally? Are you able to move that arm much? At home? Can you get it up to like hold a bag or hold something? Is that about what you're doing at home? Yeah. Okay. You just want to position over like a walker or a camp? Yeah. Well, what the heck happened to you? You look totally different today compared to yesterday. What's your understanding of what happened?
So they remembered you guys.
It didn't help.
Yeah.
So you had a big...
So he's completely clear. He's totally loose about what happened. He's figured out he's got a chest tube, and he's answering questions perfectly. It was less than 24 hours after antibiotics chest tube. So delirium is something that does get better, right? And so it's particularly common, and the important things to know is it's got this incidence of anywhere from, depends on who you read, 20% to 80%, right? It's this gigantic spread, but up to 80% mechanically ventilated patients. And every day that you spend delirious increases mortality by 10%. It increases length of stay in both the ICU and the hospital, increases your risk of post-ICU cognitive impairment too. So it does have a very real impact. So that poor guy who had delirium for one day, that's a serious symptom. There's a lot of risk factors. So pre-existing dementia or any cognitive impairment, in this case, his prior stroke, technically would be a risk factor. Chronic hypertension, alcohol use, 2 to 3 drinks daily, unfortunately, sorry guys, but that's a risk for you. And then injury severity, of course, the sicker you are, the worse. If you are coming out of coma, that's a high risk for delirium as well. And then the SCCM guidelines specifically mention benzos and say maybe opiates. There is some newer literature since those guidelines came out that suggests that if you are coming in for an operation, even a routine operation, and you have intraoperative hypotension or EEG-based suppression during the OR, that's also an independent risk for delirium too. So there's something about vulnerable brains undergoing some additional stressor of some kind that leads to this condition. There's not a specific treatment. So what I'll tell you is if you have someone who's at high risk, early mobilization is key, and that becomes obviously more and more on vogue and needs to be done. Sleep promotion simply protects that sleep cycling, so their wakefulness is bunched, and that allows you to focus better. This is all soft recommendations, but there is some evidence that maybe melatonin or melatonin agonists can be helpful. And if the delirium is a medication or medically induced delirium, Precedex is preferred to benzodiazepines. And you guys know this from the SETCOM and MINS trials that are highlighted here, that the forest plot favors a non-benzodiazepine sedation for those in medically related delirium compared to benzos. This does not apply to withdrawal syndrome-based delirium. So if you got alcohol withdrawal, use benzos, right? Although you can use Precedex too, there's some precedent for that. In terms of treatment, you also kind of hand-waving stuff, right? So what they were saying from the SCCM is atypical antipsychotics may reduce the duration of delirium. That comes from a paper with 36 patients who got Seroquel. What I'll tell you is that Seroquel dose is an antihistamine functionally. It just doesn't have the anticholinergic side effects of Benadryl. So functionally, you're giving them something to make them sleep. So you kind of come back to this idea of sleep-wake cycling. And of course, you don't want to use any antipsychotic, whether atypical or typical, with someone who's got risk for torsade. There was one study in 2004 that did this bizarre 0.5 milligram Haldol with 1 milligram per hour drip in patients who were coming in for surgery. Only 10% had urgent surgery. So all of these were like routine surgery patients with Apache scores under 10. And they showed less delirium postoperatively. If anyone uses that protocol in our hospital, please let me know. That's really bizarre, but I'd love to know how it works. But I don't think anyone's using that. And I can't imagine using Haldol as a preventative in anybody. Treating pain is important because that's a very powerful extraneous stimulation. And if the water faucet's on and nothing is being sieved, pain is going to be a big focus on that patient, and they're not going to be able to focus on anything else, including their orientation or memory of what's going on around them. And similarly, the loss of vision and hearing is something else that prevents you from focusing, right? So you've all, if for those of you who have glasses, if you take off your glasses, it's much harder to focus on things because that stimulation is no longer crystal clear. You're unable to really focus in on things. So giving our patients their glasses back or turning their hearing aids on actually helps tremendously. So where do you put it? Where do you put delirium? Who wants to stick it on the board? Who wants to do it? Samir, you want to? I'm focusing on this part of the room because I can't leave the microphone up there. There you go. You got your laser pointer. Where do you want to put delirium? Start with agitated delirium. Does it work? Can you make it go? No? Good job. That's exactly where I would put it. That's exactly where I would put it. So these are patients that are hyper-aroused often, or at least demonstrate sort of a normal level of arousal. When they're aroused, it just comes and goes. They're not nearly as aware as they should be, right? So this is similar to drowsiness, but again, this is someone who's got an acute change. This is not something that is going to go away once you maximally stimulate someone. And hypoactive delirium kind of fits on the other side. Right? They're less aroused, perhaps, but similarly, they have this fluctuating awareness. So it's a disorder of consciousness. Treated as such, it's a state that you have to intervene upon, but it has an impact on patients. All right, any questions about delirium before I move on to the very unrelated topic of TBI? All right, TBI. No videos in TBI, unfortunately. Sorry, guys. All right, so we're going to talk about TBI then. So I'm going to briefly define TBI so everyone understands what we're talking about. I want to focus in a bit on primary injury, what that means, and then secondary injury, because that's what we actually treat from an ICU and an ED standpoint. And then I want to go through some of the basic guidelines of ICU management, both from the 2016 Now Brain Trauma Foundation guidelines and from our institutional guidelines, which were approved this past, November, December. What I will not be covering, surgical guidelines. I'm not going to tell you when to operate on subdural because I am not a neurosurgeon. And I'm also not going to talk about advanced neuromonitoring because you got to come to the neuro ICU if you want to get that. So come on up. But we're just going to talk about basic TBI stuff so everyone it applies to everyone across the ICU spectrum. So everyone knows, I think, this stuff, TBI is a common or prevalent disease. 10% of the patients who are hospitalized have severe TBI, and that's most of what comes to the ICU. There's a lot of moderates, too. But there's a lot of folks hospitalized for TBI. And more importantly, if you survive, you have a lot of disability. So there's 3.2 million people in the U.S., or 1% of the U.S. population is disability related to TBI. After 3 to 5 years, when most people have recovered functional, or have recovered function, I should say, nearly 2/3 continue to have cognitive difficulties or need help with basic or independent ADLs. So it's a problem. So I'm going to give you some cases as we go throughout here. This is an 18-year-old guy who had an MVC. He was drunk on 71 and got into a car accident. He came in with a GCS of 7 and was intubated. He had a very complicated hospital course, including autonomic storming, which I think you guys have all seen, right? The blood pressure and heart rate are dysregulated and go all over the place. He had a sinus thrombosis requiring low molecular weight heparin. He had MDR pneumonia, ended up trach, PEG, and LVAD. This is your usual severe TBI story. Here's his CT scan. We'll talk about primary injury in a second. Here's his midbrain, which you can see has a lot of blood around it, maybe a little bit tight. He's got a big subdural over here on the left. He's got some cerebral edema. There's loss of the normal sulcations, and these finger-like projections of gray matter coming down into the relatively hypodense white matter. How many of you guys know about the impact scoring system? Raise your hand if you've heard of impact. All right, a couple of you guys have. So impact is an online, go to Google and Google impact TBI prognosis. This is a scoring system that came out of the impact trial before and then was validated on the CRASH data set, which is 10,000 patients with TBI. And if you've got a TBI with a GCS on admission of 12 or less, so moderate to severe TBI, which we'll talk about in a second, you just put in some data, and what it spits out for you is a 6-month prognosis, essentially, based on how much data you put in. The basics are how old you are, your GCS motor score, and your pupillary exam. If you want to add some CT findings, this guy, or CT and secondary injury findings, this guy had no peri-resuscitation hypoxia or hypotension. He got an evacuation of the subdural, so he had an evacuable mass lesion. He has subarachnoid hemorrhage, and he did not have an epidural mass, which I'll show you examples of in a second. He had a glucose of 130 and a hemoglobin of 14.9. So what that does is tells you that he has an 18% chance of being dead in 6 months, and he has a 29% chance of being severely disabled, vegetative, or dead in 6 months. 1 in 3 chance that he's going to be a vegetable or in a nursing home in 6 months. Okay? All right, I'll get back to him in a second. So here's the primary injuries. So what you can see over here on the top left is an epidural hematoma. It's this lens-shaped looking hematoma that's bright white compared to the brain. Respects the suture lines because it's outside of the dura. Compared to below it, a subdural hematoma, which is under the dura, does not respect suture lines. It kind of has more of a concave shape. Contusions or hematomas are intraparenchymal, often have vasogenic edema and can expand, right? So these are contusions if they're small, hematomas if they're big. Subarachnoid hemorrhage sits around along the subarachnoid space. You can see here in the Sylvian fissure and in between the sulci. Intraventricular hemorrhage, you can usually see layering, particularly back in the horns of the ventricle because someone's laying flat on the CAT scanner. Diffuse axonal injury often looks pretty unremarkable with the exception of maybe occasional small areas of what are shear injuries, so axons that tear and bleed in small areas, predominantly in the white matter. And then diffuse swelling, which is what we saw on that previous CT scan too, is loss of gray-white junction or sulcations all throughout the brain. So these are all primary injuries, and we classify them clinically based on their severity, and that's usually GCS-based. Most people are used to thinking of mild TBI as a GCS after resuscitation in the ED or in the ICU as a GCS of 13 to 15. Moderate is 9 to 12, severe is 3 to 8. There's a whole bunch of other definitions, though. Loss of consciousness lasting longer than 24 hours, I would call that severe too. And so there's some functional definitions that exist out there. And the mechanisms usually fall into one of these categories. RX or acceleration, deceleration. If you get hit in the head, it's a blunt injury. Blast injuries are kind of their own animal. And penetrating injuries, of course, are usually gunshot wounds. And injury severity typically kind of goes with your mechanism of injury. A fall from standing shouldn't give you a severe TBI, although it can. Fall from 20 feet is associated with severe, and MVC at greater than 35 is also seen with severe injuries. The pathophysiology, again, primary injury, the pathophysiology of primary injury. You get hit in the head, your neurons get polarized briefly. That causes loss of consciousness. That's one. You get shear injury as tearing of this axon. These are long processes that go from neuron to somewhere else and exist throughout the white matter. Those tear just like if you were to take the cable to this mouse and spin it around until it broke, right? Vessel injury, this can occur both here at the small blood vessels causing contusions as well as the large blood vessels causing dissection. And then tissue deformation, anytime you deform a cell like in tissue culture, it actually breaks, releases all of this excitotoxic stuff, and then it dies. So the same thing happens in the brain. But that's all primary injury. You can't do anything about that except for like tell people to wear helmets, right? Or show people videos of whodunit and tell them not to hit cyclists. But if you are existing in the ICU space, your patients are coming to you with those primary injuries done, and your job is to prevent secondary brain injuries. So I'm going to focus the rest of the talk on that. Secondary brain injuries are really, really important, right? So it's not just the primary brain injury, but one episode of neurodeterioration, meaning someone who gets worse in terms of their GCS scale, happens in 1 out of every 4 patients and increases your mortality from 10% to nearly 60%. And a single episode of hypotension, defined here as a systolic blood pressure less than 90, increases your mortality by 50%. It's a big deal, right? What's really scary is that when you look at a severe TBI population, 80% of them have an episode of hypotension. So you got to treat this stuff, right? 89% have increased ICP. This is all severe TBI. 87 have inadequate CPP. We'll talk about autoregulation. That's messed up on everybody. 61% have periodic discharges or seizures in the cortex, and 56% have spreading waves of recurrent depolarizations, just like you get when you first get hit in the head, only recurrent, causing additional ischemia. The main underlying problem, every one of these things, is purely supply and demand mismatch. That's all you're dealing with. Either there's an inadequate supply of oxygen and glucose, or there's too much use of oxygen and glucose. That's it. Okay? If you can address that, you're great. Here's some pictures of patients who've undergone a PET scan with their oxygen extraction fraction, which you can see along this right side underneath the subdural that was evacuated. Their oxygen extraction fraction is elevated all throughout, and their blood flow is decreased. Here's another picture of the same thing where the CMRO2 kind of is elevated in patchy areas all throughout. So there's this patchy heterogeneous increase in your OEF and decrease in blood flow. So how do you treat it? Here's the practical part for you guys. Avoid hypoxia. It seems simple enough. It increases your odds ratio by almost 3 for death. Just maintain your SpO2s. That's it. Greater than 95% is part of our institutional recommendations. Greater than 90% is part of most. So have a normal SpO2. Avoid hyperoxia. So your SpO2 may be 100%, but if your PaO2 is 340, that's actually a bad thing. And that's been shown, as you see in this forest plot, to be fairly robust. It's not perfect, but in general, the hyperoxia literature is pretty consistent, that it causes harm from reactive oxygen species hand waving or by paradoxically reducing CBF, which it actually does. It's much weaker than the CO2 receptors in terms of its ability to change the vessel diameter within the brain, but it does do it. So maintain the PaO2 at 95, 96, 97. Don't ramp it up to 100 necessarily, and if you do, make sure your PaO2 is normal. Ideally greater than 80 and less than 180. Avoid hyperventilation also. That's really important because CO2 is the most powerful chemo stimulator for vessel changes in the brain. 1 millimeter mercury CO2 changes your CBF by 2 to 4%. So as you can see in the plots here, you've got this U-shaped curve where too little CO2, less than 35, dramatically increases mortality in the worst patients and even in the more quote-unquote salvageable ones. Same if you have above 45, probably for different reasons. So the sweet spot's between 35 and 45, and that's our institutional policy here. Avoid hypotension. Here's why. Here's the autoregulatory curve in the brain. You guys have probably all seen this, but the basic idea is for any one of us in the room, if I start talking politics and your mean arterial pressure decides to go up 40 points, your blood flow will remain the same. And that's specifically because your neurons acquire an ability to, at the micro level, increase or decrease their blood flow. That's neurovascular coupling, right? Well, your neurons can't do that if they're seeing variable blood flow as an input. They have to be able to change it themselves. So if your blood pressure goes up, your blood flow in general should stay the same so that your neurons can change their own local blood supply at will. So the reason why this happens is that as your blood pressure goes up, your vessels decrease in radius. Decreasing radius changes the pressure, or the flow rather, by a factor of 4, right? So by a power of 4 rather. So this is a very effective way to maintain your blood flow. As you get lower in terms of your blood pressure, the vessels dilate. And the ICP, represented by this curve, goes up because the more blood volume you have in your brain, there's a fixed skull, which we'll talk about in a second, and therefore the more volume you transmit, the more pressure you transmit. And eventually that becomes pressure passive as the flow continues to decline. So maintain your blood pressure. There's actually some data to suggest that a blood pressure of greater than 110 is optimal and less than 110 affects outcome. So the old adage to keep the systolic blood pressure above 90 probably isn't adequate. And I'll show you some data to suggest later that the CPP, which is the MAP minus the ICP, is probably the better target and is also higher than we typically target. You can correct ICP, and of course, you want to make sure you have adequate volume resuscitation. And then this is a point that we often forget about, but avoiding hypoglycemia is actually really important, especially for folks who have multi or polytrauma, where they've hit their spleen or the liver, and they have dysregulation of their glycemic control. Hypoglycemia actually ends up being really important. So this is a study that looked at microdialysis data. Microdialysis being a little probe stuck in the brain that measures glucose in the interstitial space. And what they found was that a glucose that was less than 80, the brain glucose was dangerously low, to the point where it was actually creating ischemia, which is what you see here, represented by the lactate to pyruvate ratio in the brain, which at greater than 40 indicates ischemia. Those patients also died a lot more regularly when their brain glucose was low. At a tight glucose range, so somewhere between 80 and 120, which most of us in the ICU would be like, that's awesome, that's the perfect glucose range, right? 110, 140 maybe if you're feeling generous. Also lowers your brain glucose below the threshold of 1.8, which is under which you get into the danger zone. So really an intermediate glucose, and what I usually use in the neuro ICU is between 120 or 140 and 180 is your ideal range to prevent brain hypo, whatever that term is in Latin, hypoglycuria, whatever it's called, glucose in the brain. What was that? Yeah, there you go. Congratulations, you're a neurologist. All right, and this is another secondary brain injury pattern to be aware of and to treat. This is a head CT from a guy who had multiple contusions. As you can see here on day 1, there's contusions at here, some subarachnoid blood here, a lot of frontal contusions and shear injury, a little hematoma there. Here's day 2, wah, wah. So coagulopathy is also really common and important to treat in terms of its secondary brain injury potential. The targets are 9R less than 1.5. Platelets are greater than 100. That's modulatable once you pass the first 24 hours when a lot of this stuff happens. But in general, you want to be aggressive about correcting that up front. Risk factors that you can kind of be aware of going into a patient who's coming up to you with trauma is an older person, a person who comes in with some critical hypotension. If they have a severe TBI, of course. If they already have intraparenchymal lesions, so if they already have an ICH, they're much likelier to expand their ICH than someone who has tiny little contusions. And then if you have a lactic acidosis, also, presumably for the same reasons that you get a coagulopathy with sepsis and those sorts of things. There was recently a paper that looked at a scoring system for who expanded their contusions. They found 3 independent risk factors, not the greatest study in the world, but if you have subarachnoid blood, subdural blood, or a skull fracture, then those are potential risks for expanding contusions. And then the thing I'll spend the most time on is the thing that we tend to focus on the most in the neuro-ICU, which is the ICP. So ICP is kind of this meta secondary brain injury, right? It causes a bunch of stuff. And so we end up treating it because the ICP, as it goes up, then decreases the CPP. And as we saw on our autoregulatory graph, the lower your perfusion pressures going into the brain, the lower your blood flow. And so it secondarily decreases blood flow, causing ischemia, right? Everybody follow that logic? So by that token, if you treat the ICP, then you've treated a number of different underlying pathologies. You've treated ultimately blood flow, which will increase your delivery of critical substrates and those sorts of things. So how does ICP work? Your brain, your skull contents equal about 1,500 cc's, most of which is brain, some of which is blood, 2/3 of which is venous, and a third of which is arterial, and then you have your CSF, right? And that's kind of it. That's all that fits in your skull. If you add something else, blood or CSF, a tumor, whatever, then your brain has to compensate. Something has to change. So as you add a mass lesion here, for instance, you squeeze out some of your venous volume, you squeeze out some of your CSF, and you compensate it, and therefore your ICP can go up. This is the Monroe-Kelly curve, as you guys all know. As you increase your mass to some critical level, though, that compensation decreases, and you have a rapid or logarithmic increase in your ICP. When you get a rapid logarithmic increase in ICP, the only other thing left to compress is your brain, which goes then where it's not supposed to go, and that's called herniation. So there's a bunch of herniation syndromes. There's subfalcine. There's external if you have an external deficit, like a skull fracture or a craniotomy. There's uncal, there's central, and there's tonsillar. So those are your herniation syndromes. Things to look for are pupillary asymmetries, because all of your pupillary stuff happens kind of right here, which gets a bunch of the herniation syndromes. And then posturing as you begin the transect motor tracts coming along that same region. So you want to avoid that. So you want to avoid an ICP that's so bad that you're compressing brain, causing herniation. So who do you actually do ICP monitoring for then to catch this before it happens? Basically anyone with severe TBI, and this is our institutional protocols, kind of follow this as well as the brain trauma guidelines, which haven't changed much since 2007. But anyone who's got a GCS of 3 to 8 and an abnormal scan is appropriate for an ICP monitor. GCS of 3 to 8 with a normal scan, thought to be a diffuse axonal injury, if you've got 2 of these 3 features, age greater than 40, motor posturing, and a systolic blood pressure less than 90. And then if you do have a GCS that's higher than 8, you can consider an ICP monitor if you've got a CT scan that shows a lesion that might grow, causing you to need to go to surgery, or if you just had surgery and you want to monitor to make sure that area doesn't continue to swell despite your skull flap. So those are all good reasons to do ICP monitoring and what we do in our unit, which includes ICP along with some other stuff. It sits in the parenchyma itself, goes about 3 centimeters in, and measures pressure just in one area, usually in the non-dominant frontal lobe. So I'll show you a case now of someone in whom we treated the ICP, and I'm going to walk you through the treatment of ICP because I think it's important for everyone to realize as you go into thinking about severe TBI. Once you've avoided all these other secondary brain injury things, now you got to deal with ICP. So if you're going to deal with that, let's treat it in a stepwise fashion. So I'm going to walk you through what that looks like, and we'll do it with a case. This is a 22-year-old guy who had an MBC. He was initially a GCS 5, decreased to a 3. And this was his scan. He had a couple of contusions, the largest of which was on the left, and he had a very, very tight brainstem, as you can see here. He had a very complicated course with refractory ACP, delayed hemicrania, which I'll get to in a second, a lot of autonomic dysfunction, necrotizing pneumonia, bilateral pneumothoraces, trach, PEG, LTAC. Same story. When you stick it into his impact data, he's got a very similar story to the guy we looked at the very beginning, right? 1 in 5 chance of dying in 6 months. So now I'm going to show you what we did with the ICP so you can see kind of how it goes, right? So what you're going to look at is a panel of a whole bunch of different values. Here's heart rate over a 1 hour period. Here's blood pressure. Here's ICP. Here's the cerebral perfusion pressure, brain oxygen, and we'll skip down here to cerebral blood flow. Okay, just to kind of give you a lay of the land here, I'll point out things. And first thing you do is you stick in the ICP monitor, and lo and behold, this poor guy has a gigantic plateau wave with an ICP of 45, which should make all of you rush to the bedside and figure out what else is happening. And as a result of that ICP, his perfusion pressure drops, and his blood flow in his brain drops. And his EG even slows down. It takes all these faster frequencies and wipes them out. So this is a guy who is having a very critical ICP event. So how do you treat it? Tier 1, that's your 0. Here's what you start with, the basics. Head of the bed, 30 degrees. Neck straight, and here's why. If you rotate the head, ICP goes up. If you flex the head, ICP goes way up. If you compress the jugular, the ICP goes up, right? So you can do this in your ICU if you really want to torture your patients, but you could also just look at this graph. And then you want to give them adequate analgesic sedation. Avoid elevated temperatures, which dilate cerebral blood vessels, causing further cerebral edema. Avoid hypotension, which we saw in that autoregulatory chart, increases vessel diameter. So we did that. So we literally moved this guy's head into a neutral position. Look what happens to the ICP. Isn't that amazing? Isn't that nice? And then we sedated him. And look what happens as blood flow goes way up as his ICP goes down. So this is an effective treatment that increases blood flow when we decrease his ICP. Critical stuff. So now you've done all that. Guy's sedated. He's got his head straight. Everything is the way you want it. Afebra, all that kind of good stuff. What do you do next? So tier 1 is hypoosmolar therapy, hyperosmolar therapy, which all you guys are familiar with at this point. You can give 2%, 3%, or 23.4%. You can give sodium bicarb, which is a 7.5% solution. You can get whatever you want. You need to give it relatively quickly. 23.4 is relegated to about 10 minutes. The rest of these you just drip in as quickly as you can get them in. Mannitol you can give as 1 gram per kilogram, and you give it quickly also. So give it over 15 minutes, not over the hour that Epic tells you to give it. When you do this, hypertonic sodium is probably better. So in meta-analysis, it tends to work better for durable resolution of ICP. So we tend to use that. The other reason not to use mannitol as a primary agent, although it's perfectly fine to use and it's kind of the standard clinically, the other reason not to use it is to be aware that it's a diuretic. All the mannitol goes in, all the mannitol pees out, and now you've got someone who's now just in volume resuscitated. It might be hypotensive, right? And hypotension increases mortality by 50%. Bad. So use something that gives you some volume too if you can help it. Tier 1 also includes CSF diversion. An EVD can be placed to remove that component of the intracranial contents. And then you can adjust the CPP. So I showed you that regulatory graph, right? If your perfusion pressures are too low and your flow is compromised because your vessels are maximally dilated, increasing the pressure should bring your blood vessels down a little bit, reducing blood volume, reducing ICP, correct? Right, so you can do that by adding Levophed if you wanted to. So let's see how that worked on this guy. So we gave him some hyperosmolar therapy here. Look at that. Beautiful. ICP comes down. The perfusion finally comes up as the ICP kind of reaches its nadir. So we've restored perfusion that way. That was nice. And then we gave him some Levophed. So starting here, we felt like, his blood pressure, which is okay, is fine, but his CPP is way too low. It's 46. So let's give him some Levophed. So we started it here, and then it really kind of kicked in here. And once it kicked in, his CPP comes up, and look what happens with ICP. It goes down at the same time his blood pressure goes up. Inverse relationship, right? And his perfusion goes up nicely as well. So augmenting the CPP has clear demonstrable benefits in the right patient. And then tier 3, so you've finished tier 1, now what do? Well, now you're in no man's land. So you get to pick and choose. This is now the Chinese menu of things that you can do for ICP. You can give paralytics, which reduces the thoracic resistance to venous outflow. You can cool, which as an immediate tier 1 failed, let's go to cooling, may increase the risk of pneumonia and worsen outcomes. So only use it as a last resort. Pinabarb you can use to reduce the metabolic need of the brain, and that's been used but outside of the context of clinical trials. And then there's always decompression. Decompression's been studied in 2 trials. It's never really worked, but the way it was tried was Decker rushed into the OR immediately and showed a worsened outcome. Rescue ICP at least said maximize tier 1, and they didn't show a worse outcome necessarily. They didn't show necessarily a better outcome either. So just kind of be aware that you increase survival without necessarily improving outcome with decompression. So we cooled this guy. Look what happens when you cool him. Beautiful. ICP comes down. You get a lot of shivering before you get to goal temperature, though, but here's the temperature curve. So as he gets down to goal temperature, it did work on the ICP, right? So his temperature goes down, his ICP gets better. We also gave him some pinabarb, and we started him on pinabarb here, finally loaded him, I think, here, if I'm not mistaken. Yeah, that's what it was. We started out here, and then started a drip, and then loaded him. And when you load him, I mean, it works really, really well. But here's the problem. Look at his EEG. It totally flattens out. EEG disappears because we gave him too much pinabarb. And when you do that, the blood pressure falls. And when you do that, the CPP falls. And when CPP falls, look what happens to your blood flow. So you've got to, the risk-benefit thing, right? So you can reduce your metabolic demand, but at some point you begin to compromise your perfusion. And even a metabolic demand of 0 can't sustain neurons if they have no blood flow. So there is some risk there. And we did give him paralytics at 1.2, and the paralytics also worked nicely, but you can see the durable effect kind of was sort of an overall average reduction in the ICD, but it did work. The other thing that it did was it made the vent take over, and you could tell we were underventilating him. Before that, he was probably over-breathing, and then we paralyzed him, and now you got a whole separate problem affecting your ICP, which is why we have a target CO2 of 35 to 45, right? So all these things interplay, but the important part is the paralytics do work, despite vasodilating him from CO2. Oops. And then after day 10, the neurosurgeon said, please, you've done a great job, but just stop. Let me take off the skull. They did. And this is him a couple of days later, actually. His EEG is totally restored. His blood flow is normal. His ICP is normal. Normal autonomic variability. It looks great. 18 days later, his follow commands. And he walked back in 3 months later. Right? So treating secondary brain injuries does have some benefit. Now, don't listen to everyone who tells you no, right? The haters are still going to say, oh, but look, in Colombia, when you do ICP monitoring, it doesn't do anything, right? So the best TRIP trial actually was a randomized controlled trial of doing ICP monitoring. But bear in mind, this was a third world country. They had 44% of the patients with one or both pupils that were unreactive. Yeah, it's a little hard to apply that to our patients, right? There's some other credible data that ICP is important, namely that if you do hourly ICP, which is what most studies look at, it misses nearly a third of patients who have elevations in ICP above critical thresholds. And frankly, the time spent with those ICPs that are above critical thresholds is really important. An ICP of 20 for 30 minutes puts you in the red zone, increasing your odds for dying by 10. But an ICP of 15 sustained for more than 3 hours does the same. 15, normal ICP, can increase your chance of dying if it doesn't come down. So this is one of those things that's kind of understudied, unfortunately. And part of the reason why may also relate to this autoregulation thing. So I mentioned autoregulation earlier. Here's a normal autoregulatory cascade. When you have TBI, this is abnormal very frequently. And when it's abnormal, you can generate an optimal CPP, and it ends up being 70 to 80. How many of you keep your CPPs above 60 in TBI? Everyone should raise your hand. Above 60 in TBI? Right. How many of you routinely keep your CPPs above 70 in TBI? Well, in a population study, that's actually where you should be. So your patients actually, in some respects, may be under where they need to be. And when you get to 10 or 15 off from that goal, your mortality comes up substantially from being kind of right on target. So just like our blood pressure goals used to be 90, now they're 110, our CPP goals probably should be greater than 70. And you can do this in real time, too, as it changes in a given patient. Case 3, I'll touch on a couple last things. I don't want to go too far over. This is a 21-year-old who was going 140 miles an hour on his motorcycle, but he had a helmet on, so that's cool. But then he wrecked. He had non-convulsive seizures and came up to us day 2 or day 3. Had a bolt placed, and then had a hospital course complicated by autonomic storming, got trached and pegged and went to LTAC. It's all sounding familiar. His prognosis was actually pretty darn good, right? 7% chance of dying, 19% chance of being vegetative or severely disabled. And here's his CT. He's got a really tight brainstem. He's got a shear injury across his corpus callosum. So pretty significant DAI. But here's what I want to show you. This is a guy who we put in the bowl, and we saw his perfusion was basically Zippo. He wasn't perfusing anything. His CBF was well below what it should have been. Normal is 15 to 20. He was 5 to 10. And we looked at a CPP and said, look, a CPP is about 60. It's kind of 55 to 65. It looks okay, but his CBF sucks. So let's add levofed. We pumped up his blood pressure. When we did that, we saw his ICP go down. But what's more important is look at his blood flow. At the same time we increased his blood pressure, his blood flow goes up and up and up and continues to go up. It's sort of like we recruited his blood vessels, right? and his CPP maintained, or CPF rather, maintained a normal value from there on out. What's really striking about this kid is right before we put in the bolt, actually this was the post-bolt CT, this is post-bleed, or this is trauma day 0. Here's a CT scan, 3 different slices, trauma day 0. Right? Here's, right as we put in that bolt, we saw the CBF reading 0. Here's the CBF probe, but look at this, big old patchy stroke, both sides. Look at that. We increased the CBF, that's all we did. We increased the CBF, gone. Next day is the next day, totally gone. Ischemia is totally gone. So this is a reversible stroke, basically, right, by augmenting CBF, targeting a CPP that's higher than you might otherwise normally target, again, trying to avoid hypotension, which is the major secondary brain injury. You could do all this stuff, and you should. So a couple last topics just to cover very briefly in TBI. Secondary brain injury is related to large vessel dissection. Please be aware this is a thing, and I think most of us get the CTA and the ED before people come up. When you go to your next place of employment as an ICU doc, you might have TBI, and it may not be a place that does ED the way that Cincinnati does it, which is awesome. So when you go to another place and their ED doesn't do as good a job, be aware that CTAs are actually really important for the following scenarios. C-spine fractures that particularly go through the transverse foramen, Lefort 2s and 3s, poor or severe TBI, and anybody who's got a seatbelt sign. Please get a CTA. And the reason why is that it's common to have these vessel injuries, and they impact outcome. So here's the grading system that's used and the number of strokes that occur in each grading system based on the big series out of Parkland. And we've seen cases of that here too. Some of you guys may have been in the SICU, and this lady was here, but she was 29, had an MVC. Her initial GCS was 14. She was great. Here's her impact score. She had a 1 in 10 chance of being disabled before she, by 6 months. I mean, she had no chance of being disabled. You talk to the family and say, 90% chance, she's going to be great. She went to the OR because she had a big spleen lac and a diaphragm injury. And when she came back from the OR, her GCS was 6. Her pupils were sluggish. She looked awful. And here was her original CT. Here's her follow-up CT. She's got multifocal strokes, but these are not the kind we were just looking at with the other guy. This is not a lady who had ICP issues and decreased perfusion. This is a lady who had 2 big vessel injuries. In her left ICA, you can see this finger of crap sticking into her ICA. And on her right, she has these chunks taken out as well. So she actually had ischemic stroke from embolism from these events, which happened at the time of injury. Right? So she had evolving infarcts. Now, as it turns out, even though they were bilateral, she ended up waking up, and she had to be trached and pegged because of the ARDS, but she's in a nursing home awake with a mild left hemiparesis, and she's going to recover to some degree. But those are things to be aware of, because if you don't know about them, you have a patient who's a GCS 6 post-op and you don't know why. And then there's seizures, because I would be remiss not to mention seizures. Early seizures are not epilepsy. Early seizures occur within 7 days of TBI and are not epilepsy, but a reflection of the brain injury. Right? Half occur less than 24 hours out. The incidence is about 1 in 5 patients have them. No study has been done really on continuous EEG-based metrics of this, except for a couple of series that have come out recently, and it's somewhere around 1 in 5. So just be aware that your patients may be seizing. 1 out of every 5 of your severe TBIs in the SICU or MICU are going to be seizing. Risk factors largely are ICH. If you got blood in your brain, that's an irritant. And it's an important thing to recognize that it increases ICP, it increases midline shift if you have ICH, it increases that metabolic supply-demand mismatch that we talked about. And so it's worth treating. This is a 21-year-old guy we had here who had a big subdural, was evacuated, and then on post-op day 1, he developed this left parietal seizure phenomenon. What's interesting is 9 months later, he developed a right arm, hand, and arm numbness, lasting 1 to 2 minutes. So he actually developed post-traumatic epilepsy. So how do you treat this? Fosphenytoin is the gold standard, which comes from a clinical trial that was done back in 1990. Now we have Keppra, which should be better, but it's not really been well studied. There was a study here in 52 patients that suggested it did okay, and a non-randomized study of 813 patients. Similarly, no difference in seizures. So yeah, maybe Keppra works, but there's no firm recommendation from the brain trauma guidelines. So we tend to use Keppra. And the load, you can do kind of a half load, just a gram Q12, and then stop it. It doesn't impact post-traumatic epilepsy. It's just the early seizures that it treats. So you want to use this in patients who can't take a joke. If they seize, and that's going to cause a problem, you probably should prevent the seizures. And so that's important to recognize. Depakote, incidentally, which should be great for these patients because it's not as sedating as Dilantin, actually had a trend toward mortality when you look at the 6-month outcomes of those folks. So don't use Depakote in any of these patients with post-TBI risk for seizures. And then some final recommendations from the brain trauma guideline, and I'll end here. Post-traumatic vasospasm is a thing. Patient's not doing as well as you want them to do, get TCDs. Feeding is important. We all know that. I think everyone tries to feed here, but 5 days is kind of the recommendation. And they recommend vaginal feeding to prevent aspiration. Low molecular weight heparin, the guidelines are from here. Brain Trauma Foundation kind of says, eh. So we use low molecular weight heparin preferentially in null trauma 24 hours after stable CT or 72 hours after spinal surgery. Steroids are always contraindicated. This comes from a crash trial, which was 10,000 patients. Don't use steroids. And avoid early prognostication. So remember case 1, I never followed up with you about that, I'm sorry. Case 1 has a 1 in 3 chance of being severely disabled, vegetative, or comatose. He has a horrible looking brain. He had a horrible course. Give him 30 months. Give him 30 months. He finished high school. He came back in the Sally. So avoid early prognostication because particularly in the young folks, these people can actually do really, really well if you mitigate all the secondary injuries that come with their ICU course. All right, I think I finished right at 2. Any questions?
In the traumatic dissections, is there a study that reduces the rate of stroke, like any intervention that early on?
No, the biggest study was, so the recommendations tend to be aspirin or heparin, and they leave it up to the clinician. The biggest study was that Parkland series, and they basically reported how there was variability in practice, and they couldn't make really heads or tails about what worked and what didn't. So institutional guidelines are usually what we go by. BIFL 1s get aspirin, BIFL 2s get aspirin or heparin, most of the time heparin, and then 3s and 4s similarly get heparin. But that's, again, institutional, and I don't always agree depending on the patient. It just depends. You know what I mean? So it's a consult ultimately, and you just kind of take it as you can. Any other questions? All right, cool. Thank you guys for the marathon.
He did like so much better than things I did.
What's up?
Mr. Steve,
Yeah. Oh yeah, the guys that.
because I talked to you about the one questionable seizure that he had. He like stopped having apnea after that. He did so much better. He got